This week on the BackTable podcast.
I will see the CT scan. And the CT scan, I have a couple of questions to be answered. First, how long is the occlusion? Second questions, if any, it's SVC only, straight, long occlusion, short. It's the third question is any curve on angle I see in the occlusions. And the fourth question is also what's the nature of the occlusion? It is calcified or fibrosis. How much of the native vein or space in the mediastinum is left that I can negotiate and move my needle with less risk to recanalize. So these questions determine the axis for me, but most of the patients I will do multiple scrubs or multiple axes, and I think you can do sharp and any axis you want. You can come from the neck, you can come from the arm, and you could come from the femoral, depending on which is available, what's the tools that you have, and what's your comfort zone with these materials, and how you can approach it.
Hello, everyone, and welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. Now, a brief message from our sponsor. RADPAD was developed by physicians for physicians. Clinically proven radiation protection during cine and digital subtraction angiography. Don't bet your career or your health on anything less. Trust RADPAD radiation protection shields for all your fluoro-guided interventions. See radpad.com for more information and contact info@radpad.com for a free radiation evaluation and a no-brainer radiation protection cap. And don't forget to tell them that you heard about it on the BackTable podcast. Now, back to the episode. Today we have a very special guest coming back on the show from way back when, early, we're talking early days, episode 8. Where we had Abdulaziz Alharbi coming on from Saudi Arabia. We did episode 8 about IR in Saudi Arabia, where he kind of gave us an idea of what his practice was like. That was 2017, I think.
Yeah.
That was a while ago.
We're getting old, yeah.
Yeah, that was like 5 years ago. It's crazy. And I went back and tried to listen to it, but the audio is so bad. But welcome back to the show.
Thank you so much. Thank you for having me. Thank you for the invitation. It's very, very amazing what you guys doing with BackTable, and it's my honor and pleasure to be with you guys today.
Yeah, no problem, man. I reached out to you recently because I wanted to see, it had been a while since we touched base, and I wanted to have you back on because I've seen you post, we've all seen you post some pretty crazy cases recently, specific to SVC syndrome and, central venous occlusions in the chest and upper extremities. And so we've been wanting to cover actually sharp recanalizations for a while now and just hadn't had anybody kind of pop up. But, you show these amazing cases and I was like, oh, this is perfect, and so I reached out to you to see if you wanted to come on. And for the audience, what we'll do is we will link to those Twitter posts in the show notes so that you can see them. And feel free to comment. I know you got several comments and some kudos for those cases because we all know that these patients are really suffering, especially the dialysis ones, the cancer ones, and it's pretty amazing when you can open up those vessels for them. But first, what's your practice look like nowadays? What kind of cases are you doing?
So I work in a very big center, a tertiary hospital in Saudi Arabia. And it's basically called King Abdulaziz Medical City and King Abdullah Special Children's Hospital. It's a Ministry of National Guard. And it's basically a capacity of almost 2,000 beds. So we have trauma centers, transplant centers, oncology centers, pediatric centers, and women also center, women health center. So we do in vascular interventional radiology almost like 70 to 80,000 procedures per year. So we see a lot of patients, and including also dialysis patients. So basically, what we see in dialysis patients, we treat a lot of fistulas, and also we provide vascular access, which is all done by us. And in those cases, we follow up these patients. Most of the SVC occlusion syndrome or SVC chronic occlusion come from dialysis. However, is also because of we are transplant center, we have also a couple of recanalization we do barrier to transplant because the surgeon prefer to have an open veins in the chest to place their central line and to avoid exhausting femoral access during transplant and after transplant. And also we have a couple of cases with the patients as a symptomatic patient with SVC occlusions, either due to chronic line or previous lines intertwined. So these basically the indications or type of patients that we see.
Okay. So you mentioned there's mostly dialysis patients coming to you, or are you seeing a fair amount of cancer patients as well?
We see also a couple of cancer patients, but most of them are come as a SVC syndrome, as acute phase, rather than chronic obstruction. And we see a good number of them and usually treat them too.
Yeah. And what about, are you seeing any sort of granulomatous disease, sarcoidosis, or some, maybe even radiation with scarring, anything like that?
I don't think we see a lot of sarcoidosis in the Middle East. However, a couple of cases I think we saw related to radiation, so it's not a great volume in these cases.
Right. So it sounds like the vast majority are end-stage renal disease patients who have just limited access, have had dialysis catheters, and that's basically been the main culprit for SVC occlusion.
Yeah,
okay.
Totally agree. Yes, there and transplants too. So pre-transplants, they usually need vein opens in the chest. So we do a couple of them, yeah.
Is it innominate or brachiocephalic in Saudi Arabia?
It's actually both. But I call it brachiocephalic. Yeah, for me, it's brachiocephalic vein.
Yeah, that was Bharat's question is, which term are you guys using? So going forward in this podcast, let's use brachiocephalic. That's my preference. So for patients who have, let's say, SVC occlusion, brachiocephalic occlusion, how are you deciding who's a candidate for recanalization?
Yeah, so basically when we being consulted by other teams regarding patients, and some of them coming from other hospitals, we assess the patient, what his dialysis access is, and is the patient symptomatic or not, is dialysis access is working or not, is the patient for transplant, and the transplant is on hold because of the SVC occlusion. And after that, we clinically assess the patients in our clinic to see if any signs of symptoms, what's going on with the fistula. Sometimes we request imaging, and those cases usually filters to the next stage, which is planning and further investigation. And when we decide to do that, you usually request a CT scan, which is I think is very, very important in these cases to decide if this is doable or not. So CT scan, which is with contrast, it's usually almost mandatory for me to make sure what's going on there. And from there, we can decide if this is doable or not.
Would you say most of your discussions are with nephrology on, trying to get this done, or vascular surgery or cardiology? Like when you're getting these patients, who are you usually discussing that with?
Yeah, so it depends which service is sending the patient, but we have a multidisciplinary team, so we need to be on board, all of us. So sometimes surgeons involved as well as a nephrologist.
Yeah,
and sometimes it's directly coming from nephrologist, especially if a dialysis issue, and if the patient coming for a transplant. We usually discuss this with the surgeon as well as the transplant nephrologist or transplant nephrologist, yes, to see what's going on, because you need to take these patients case by case, because there is no typical approach for all of the patients. So depending on what the patient need and what is the next step for the patients, we further discuss the options and try to go toward the best option for these patients. And some other hospitals I've worked in, they have usually something called vascular access board, which include vascular surgeons, also nephrologists, and also interventional radiologists, which usually discuss these cases.
And so when you say transplant, are you talking about patients that are having kidney transplant?
Yeah.
Okay, so you talk about workup, obviously, imaging is important. Labs, is there anything in particular that you're worried about when it comes to labs for screening these patients?
Yeah, so you need to take the patient as a whole. So we usually investigate everything. What's the comorbidity the patient have, what type of surgery he have, and also what's the situation with the heart, what's the situation of dialysis access, since when he has dialysis, since when he has the small functional symptoms. All of that we included into the assessment, the initial assessment.
Yeah.
Then usually we request all the related labs, which is echo of the heart, and also typical blood work, coagulations, electrolytes. All of that should be included at the first assessment as every patient. And we usually filter these patients and depend on what we find out in these assessment if the patient is suitable for sharp recanalization or recanalization, because most of these cases is done under general anesthesia, and you need to make sure the patient's fit for these type of procedures.
Yeah, so like that, I guess that was one of my questions is if you're planning on doing a sharp recanalization and there's it's for an SVC, do you have parameters you're going by in terms of like making sure they're off blood thinners, or, is that something that you're just like, well, I'm going to have to put them on blood thinners later anyway? I imagine if you're worried about cardiac tamponade, then blood thinners would be a bad thing, right?
Yeah, so it depends on the finding on the CT scan, or how long is the occlusion. Usually, most of the cases, I prefer to stop anticoagulation before, unless it's necessary that the patient be on anticoagulation.
Yeah.
And also, at the end, you need to make sure also that the patients have anything else related to that could cause possible complications with these anticoagulation. But because most of the sharp recanalization, you actually going through either fibrosis or extravascular, so you don't need to take the risk to have a bleed in the table.
Yeah.
I can deal with what I do after, because already it depends what it's happened in the procedure. You can decide if you put the patient anticoagulation or not, but most of the patients I will stop anticoagulation before.
Okay. And what kind of risks are you talking to the patients about ahead of time when you're getting your consent? What kind of things are you telling them that could happen?
So in the planning section, when I see the imaging and I see everything about the patients and assess the patients before I see him, I usually put a plan and put the possible complication depending on what I saw on the CT scan. Because let's be honest, if you are doing like a focal or short occlusion, it's less risky in my opinion, rather than you're doing a long occlusion. And if you are doing an occlusion that have an angle or a curve, then you have more risk. If you're doing lower SVC, which is at the heart level, you are more risk of tamponade, as you said before. And you need to make sure also of the comorbidity and situation of the heart of the patient, because you also will be afraid of pulmonary edema after you recanalize the SVC.
Oh, okay.
So all of that depend in every patient. You take him as a special case, and you can discuss the related complication, including also the general complications of the accesses, like ruptures of and one of the most important, which I always tell trainee that work with me, you need also to explain to the patient that you can fail. You cannot do anything.
Right.
You can try, but you need to include in the informed consent that we will try, but sometimes we fail. So this should be also informative to the patient.
Yeah. Okay. Great. So let's talk about approach. Okay. So you've done the imaging, you've worked them up, you've talked to them, and you have an idea of, okay, I got to figure out how many places I want to access, where I'm going to access. How do you determine access? I mean, I know there's the imaging, but this is a question that Baratza had. Can you do a sharp recanalization from pretty much any access, or just from certain sites, from certain directions?
Okay, it's a very important question, and it's dependent on what you see in the imaging. So let me rephrase. You remember where I told you that I have 5 points that in any cases, and especially sharp recanalization.
Yeah.
So first point is why I'm doing it, and when I do it, which mostly elective, unless it's SVC acute syndrome, and the how. It's basically the third question is the how, and mostly the majority of this section is planning. So CT scan, and previous venograms, if the patient have, it will give me a hint to choose the axis. I usually scrub patients in multiple areas, so I usually scrub the neck, both arm if I'm planning to do bilaterals, and one of the femorals. It's very important to have multiple axes before scrubbed already. Second thing, I will see the CT scan, and the CT scan, I have a couple of questions to be answered. First, how long is the occlusion? Second questions, if any, it's SVC only, straight, long occlusion, short. It's the third question is any curve or angle I see in the occlusions. And the fourth question is also, what's the nature of the occlusion? It's calcified or fibrosis. How much of the native vein or space in the mediastinum is left that I can negotiate and move my needle with less risk to recanalize. So these questions determine the axis for me, but most of the patients I will do multiple scrubs or multiple axes, and I think you can do sharp in any axis you want. You can come from the neck, you can come from the arm, and you can come from the femoral, depending on which is available, what's the tools that you have, and what's your comfort zone with these materials, and how you can approach it.
Do you ever prep the chest as well in case there is a tamponade and you have to perform a...
Mostly it depends. If it's lower SVC, yes, I usually scrub the chest. Yes, I scrub the chest, and for any possible complication, either tamponade or pneumothorax. So
have you ever had that happen?
No.
Knock on wood.
Thankfully, no, not yet. Not yet.
Good. All right. Well, thank you for that. That's I love when people have an algorithm for everything, especially workup. So it sounds like you have an algorithm for determining access, and then the day of the procedure, what are the essentials that you have available in terms of tools, equipment? Are you using cone beam CT? Can you tell us kind of what's on your back table when you're prepping the patient out?
Yeah. So most of the cases, I prepare the materials myself before and see what I have before I decide to do the procedure. So the things that I need to know, which the needles that I have, which type of needles that I have that I can do, because you have short needles, long needles, what type of wires, catheters, and also what type of stents. You need to have a stent. You need to have multiple options that in case of rupture or in case of lung segment, you need to see the stents that you have. And also cone beam CT, I think it's a very nice tool to use. I don't use it that much, but it's very nice tools that to do it in the first couple of cases, because you can see your track and you can see your progression, especially with the needles. And also it's very important, which I didn't mention before, you need to know your support group. So you need to have multiple operators or someone to help you in cases of in these cases,
right.
And you also to make sure that other teams or other colleagues is involved, that you are doing a sharp recanalization, especially difficult cases like cardiac surgeons, vascular surgeons, and also you need to have, most of these cases, you need to have ICU bed in advance, like preserved for this patient in case of any complication. I don't think there is any special thing that I do pre-procedure except to see what is available. So every center is different. We have thankfully we have a lot of materials that in our BackTable that we can use, but I don't think it's available in every center. So you need to see and assess the essentials things which I mentioned before that will conclude your success or this procedure.
Yeah, I was just curious if there's any certain wires, like the Glide Advantage wire I really like.
So specifically, and when I do any recanalization, we usually start with the regular like angle catheter and trauma wire, like Glide wire.
Yeah.
And we try and depend on CT scan or prefer which axis I want to use, and then I will use it. And I usually time myself because this is a GA procedures.
Right.
There's a radiation to me and the patient, so it's very important to time the procedure. So I'll try a couple of minutes. If I failed the first step, which is angle catheter and trauma wire, I will shift to OIT wires. And my preferred wires actually depend on if it's straight occlusions or if it's angle or curved occlusion. I prefer Command OIT wire. I like this wire, and Advantage OIT. This is two wires that I usually use in these recanalizations.
Okay. Yeah, and you mentioned something earlier that I want to touch on. So you'll actually have, because you have multiple accesses and you can't both, push the needle and snare, I imagine you probably have a colleague, another IR, working the femoral access while you're in the upper extremity or in the IJ. Is that correct?
Some of the cases, yeah. Some of the cases we have fellows.
Okay.
We have a great fellows here. So and we have a big program. So we usually involve them in these cases. So sometimes they will come from the femoral. Sometimes they will help with the sharp itself.
Okay.
But having multiple operator, I think, is very important to shorten the procedure, and also to think out of the box and give an opinion and try to discuss. When you discuss things during the procedure into the room, especially if you are stuck, you usually the discussion between two colleagues will promote solutions in the spot.
Okay. All right. So let's walk through how basically a sharp recanalization works. I mean, walk me through your typical kind of escalation algorithm, and maybe even just use one of those cases you posted as an example. And then that way the audience, if they want to look at your images, they can kind of imagine, as you walk through it. Does that make sense?
Makes sense. So what I do first, dependent CT scan. Let's suppose I saw the CT scan and I'm seeing that there is track of contrast coming from the left brachiocephalic or subclavian or from the left arm. So I will try to access the left arm veins first, go with the sheath, and I usually go with just 6-7 free sheath immediately. Then I just do a venogram and try to do a recanalization, to attempt recanalization with a like angle catheter and trauma wire. If I fail, I'll go with OIT wire, and if I fail and I'm timing it myself, then I will try to go from other axis before I go to sharp. So I need to exhaust all axes before, or I try all axes that I planned from the beginning. So sometimes I just go from the femoral and try to attempt recanalization from there. And if I fail again, then it's very important to depend on what I said before. The CT scan is very important. I cannot emphasize more. CT scan will tell me which axis is better in sharp recanalization.
Yeah.
So let's suppose, I'll give you an example. One of the cases I posted, it was left upper SVC and brachiocephalic junction occlusion, and when I did the CT scan, I saw a small vein in the position or expected part of the IVC, in jugular, internal jugular on the right side, and I saw that the arm veins actually patent. So I decided from the beginning to scrubbing the right arm and the neck and the femoral, and I tried from the neck first, because most of the cases, especially when dialysis patients have a previous central line or permacath, going from the straight axis from the jugular, it makes sense. And how can I explain it? It's like a straight track of fibrosis.
Yeah.
So actually, it will work not against you, it will work with you, and using sharp recanalization. If I fail all of the manipulation of the wire, then I will decide to go depend on the occlusion location and the length. So let's take the same example I said. The right side is upper SVC and junction in the right side. So either I go from the arm and try to recanalize the SVC, the junction in between the SVC and the brachiocephalic, or I can go from the neck. My preferred choice all the time, most of the time, I like the neck, because the neck will give you a straight angle or straight track into the occlusion. Just one hint and one tips: most of the vein, especially going from the neck into the chest, have a posterior curve.
Right.
So it's very important to have a little bit curve in your needle, depending on what you saw in the CT scan. So I usually use in short segment, if I'm coming from the neck, I usually use a Chiba needle, 20 gauge, 20 centimeters or 15 centimeters, and I will use a short sheath, 5 or 11 centimeter, depending on how long the distance between the occlusion and my axis in the neck, and I will shave it or try to curve the needle to correspond to the finding in the CT scan. Then, when I decide to go for it, I usually do it in very slowly, and I do it in multiple projections. So we have the advantage to use the fluoro in multiple angles. So I'll do it in multiple AB, obliques, and laterals, and just advance a little bit and try to put in my mind the 3D image that I saw on the CT scan, and just to advise. And it's good to have a target. And if you have a short occlusion, you can go from the femoral axis or from the arm axis and just put for you a target like snare, balloon, or whatever you have and you're comfortable with. That will make it easy for you to track your needle into to the target and just try to hit it. This is in a very simple short occlusion. In the same case, if you want to do, I did a similar case, or we did a similar case, which the occlusion actually going to the right side. So you have the advantage to come from the arm rather than coming from the neck. Let's suppose that there is no veins at the neck at all, and you want to just connect the right side, because as we said before, every patient is special. Let's say the patient have a fistula in the right arm, and now he has occlusion. The fistula is malfunctioning. You don't need to recognize the jugular. You don't need to recognize the other side.
Yeah.
You just want to recognize the right side into the SVC. So in these cases, I will go from the arm, and if the occlusion is short and straight, you said it before, you can go with the back of the wire if you want. Just put a balloon from below and just puncture the balloon. And it depends on the finding of CT too, because if it's only short segment of fibrosis and there is no calcification, usually the back of the wire will go easily.
Sure.
So you can advance it slowly and just into your target. Other options, if the sharp of the back of the wire doesn't penetrate into the balloon, or you just push it and it's going away, then another options you can use a TIPS needle.
Yeah. But real quick, with the back of the wire technique, are you then also using something to direct it, like a Compi catheter, to direct the back of the wire towards the balloon? You know what I mean? Like if you got your Compi catheter all the way up to the occlusion, and then you're able to kind of angle it towards the balloon under fluoro, that's what I imagine you doing. And then like you said, it's a short segment, so you're able to kind of direct it right towards the balloon like that.
Yeah, exactly. So if you have a short and straight, you can use an angle catheter. Some of the angle catheter, some of the brand or some of the companies is very soft tip.
Yeah.
So when you push the back of the wire, usually straight up.
Yeah.
However, if you wanna use an MBA catheter, or some of the company have very rigid MBA catheter, so it's, the directional or the curve is very nice. So I agree. Most of the cases you need to have the back of the wire come just immediately at the occlusion. So using of an angle catheter, it makes sense to direct your sharp recanalization.
Would you be able to get a long sheath up there to give you that extra stability to not push back the catheter? You know what I mean?
Really, it's a very important point, and I really thank you for the information. Access is very important. The way you access the vein, where is you want to access the vein. You need a straight access into the vein. You don't need the multiple curves that will affect your support. Using of long sheath is also very important. Yeah. Because you want your sheath is as much as near the occlusion and your catheter too. Then you can direct it very easily, and you don't have back pressures to push your catheter away. Yeah,
that makes sense. Because like you're saying, going back to the IJ, IJ you could have a short sheath, right? Because it's not very long distance to get down to the SVC. But if you're going from if it's a fistula case and you're going from the arm, I'd imagine you'd have to get a longer sheath all the way up to right on top of that occlusion. And then I guess you would still use something like a Compi or an angled catheter with some stiffness to it, so that once you get the wire across, puncture the balloon, then you're able to push your catheter across, and then you just try and follow it with the sheath right then and there.
When you just puncture, sometimes you will try to push the catheter first.
Yeah.
The catheter doesn't go, so you just snare it. You just use you just snare it and use the pressure of pulling from one side and just trying to advance slowly, and usually your catheter will track. If the catheter doesn't track, then you have the options for using a low profile balloon or 18 balloon, and just go through this occlusion just across and have the balloon a little bit across the occlusions. Try to dilate with the small balloons to have a little bit space. Then you can push your catheter and just shift your system to a bigger system or 35 stiff wire. Then you can do the further ballooning and if you decide stenting.
Yeah.
This is all example of, this is all related to the example that we gave is short occlusion. It's upper SVC,
right,
which makes sense to do it. If you fail to do it with the back of the wire, then you can do it with others. Depend what you have. You can do it with the TIPS needle, transeptal needle, sometimes even Chiba needle if you have long and you're accessing the arm a little bit above, like near the occlusion, and in a very thin patients, you can also use it. But if you have long occlusion and you have like SVC complete occlusion from above to immediately to the heart, these cases usually you need multiple access. You need to be careful when you do a sharp recanalization in these cases, because you don't want to cause a complication or cause tamponade. They will make it approach a little bit different regarding which access you want to use. Back to the first question. So if you have a long SVC occlusion, the best to go from the femoral. Just to have a straight line and support to long sheath and catheter, and just to drill a little bit into the fibrosis. However, in some cases, in one of the cases that I posted before, we did it in our center, we usually went from the neck because of the finding in the CT scan, which was a calcified occlusion, and we thought that with the curve in the upper SVC, because we wanted to do a central line and permacat, would be very difficult to reach up to jugular from down. So you just try to drill a little bit from down and put a target for you, or go from above and just then continue from above and just try to track your needle into the SVC or the fibrosis into the heart. And I think when you go from the neck, it's actually safer than going from the femoral. I don't know what people have an opinion about it, but I like go from the neck, because when you do an X-ray, an oblique X-ray, you can see almost like a chest X-ray, lateral chest X-ray. So you can see the structures, or at least expected locations of the adjacent structure. So when you off, you can retract or stop and try to do a combeam CT or something. But most of the cases you can go up to sharp from the neck up to into the heart.
So it sounds like it's maybe fair to say you prefer going in from the neck, which actually makes sense for short occlusions. But when it's a long occlusion, then a femoral approach is probably just more straight. It provides more of a straight line, and that's where you tend to go from a femoral approach. Is that fair to say?
Yeah.
Okay.
Especially if you have a lower SVC, even if you have like small millimeters of patent lower SVC, it's better to go from below. I think it's much safer and much easier to drill from down.
Yeah. And I mean, it makes sense where you can imagine your structures going from above especially on the lateral and obliques, whereas when you're going from below, you're in the right atrium, right? So you might be kind of floundering a bit when you're trying to figure out where you're at, because there's just more space there, right?
Yeah, exactly. So and then you don't have a target. If it's a long occlusion, you cannot see your target. You cannot see your target in the neck. Even if you have an access, the neck is far away. Even with the venogram, you will not feel comfortable to advance it with the movement of the heart. A long sheath, the support will be a little bit difficult. But when you go into this patent lower SVC, and you just have a support long big sheath or an intermediate sheath, and now you have almost a straight line, you may get success in these long occlusions, but it's better to go, in my opinion, from the neck and just go down.
Yeah, it makes sense. I mean, you can do a venogram from above. You can't really do one from below because it just goes into the heart, right? It's just kind of,
Yeah.
All right. Well, so thank you for explaining that. I think, so you did kind of give us your needle of choice. And is there a certain snare that you like to use for these when you're snaring the needle or the back of the wire coming across?
I don't have actually a preferred snare, whatever available, but a single loop is very important. I think it's much easier.
Yeah.
It's much easier, and depending on the space that you have into the vein, either by CT scan or venogram, you can choose the size. However, if some tiny spaces is very difficult to open the snare, but I prefer a single loop because as a target it's very easy to see it in multiple directions rather than, and if you hit one of if you have to the center or and you have like a big space you can see, or a big target that you can see, so you have like multiple choices to go a little bit up, a little bit down, and just hit it rather than using other snares, which sometimes make it difficult to open it.
Yeah. Sabine wanted me to ask you, have you ever used anything crazy as a target, like an Amplatzer plug? I guess he's heard of people doing that before, like instead of a balloon. Have you ever heard of that or done that before? I guess because you can retract it back in, maybe.
I don't think I used it before. I saw people, I don't know, I saw a case, but I don't know who did it. People used some retrieval, like some small stents or plug, but I don't think I need it before or tried it.
Yeah, that sounds expensive.
It's very good. It's very good to have it in my mind, but I think a snare and balloon is a little bit cost effective,
right?
Right. But it's good to have another option. So Sabine always come with very nice options. So
yeah.
So maybe next case I'll try it.
He also wanted me to ask you about, have you ever used an RF power wire?
No, I remember I did it, but not in Venus, and I don't think it's approved in our country yet. I don't know why, but I never used it before.
Yeah,
I think it would be a great option, especially in very straight occlusions. I think it's a very good option. I'm not sure about if a curve or angled a little bit occlusion, it would be safe to use it. But I don't have experience, honestly. Maybe so you guys in the States use it like and have more experience in it than us.
Yeah, I mean, I haven't. I've never seen anybody use it, but again, it sounds like Sabine's practice, they get all these like fun tools, and it seems like they have a little bit of everything.
Yeah.
So now that we, let's walk through this hypothetical case. You have access, you've gotten across, you've snared to the other side, and you've pulled the wire across, and you're going to balloon and then probably stent. What is your stent of choice in the SVC and or brachiocephalics? And Ali Bahedi wanted me to ask any tips for stent sizing, especially through an occluded vessel.
Okay, so depending on the etiology itself and the occlusion itself, if it's short or long. Let's suppose the same case, it's at the curve between the SVC and brachiocephalic. I really, if it's short occlusion, and after I do angioplasty and I do the venogram and see how is the flow, I usually prefer to do self-expandable stents in these curve areas. I don't like to do balloon-mounted or cover stents. I just use a pair of stents. Regarding the sizing, it depends on in the patient's body nature and also in the arm veins. I prefer to go like large size as much as I can, especially in the brachiocephalic patients, especially in the patients if they have fistula. I usually go with 12 stents, 12 millimeter stents. And the SVC is a little bit different if it's long segment or short. If it's long segment, I prefer to do a cover stents because you don't know exactly where your needle went through. So you don't want to take the chance, and also to prevent stagnation of the flow. So I just go with a balloon mounted stent. and the sizes I will go as much as I can, like between 40 to 60 millimeter into the SVC, because you don't want to use this. If you use a big stent and then the flow was great, that's be it. But if you use a small stent and the flow occluded, then you will have another problem now, because you cannot do anything about it. Just if you want to use another stent in the future into it, it will be a little bit challenge too. So cover stent, I don't know if you guys want the brand that I use, but if it's okay, I can say it. I think I prefer VBX stent. Believe it or not, I like VBX stents, and then the SVC. And they have the 8 large, which you can upsize it with the balloon up to I think 40 to 60 millimeter, and the short segment in the curve or the junction toward the right side, the left side, I just use self-expandable stents. Any big venous stents is adequate.
Do you ever get worried about like stenting into no man's land? And, it's too short, and then you inject and you're nowhere. Have you ever had that happen or seen that happen? For a sharp recan case?
Thankfully, it didn't happen to me. I saw it a couple of cases. The people stent. I think it's dependent in your angioplasty and venogram.
Yeah.
When you do an angioplasty and you open the occlusion and do venogram, you need to make sure where exactly the extravascular space that you went through, and how long is it, and where is the native vein. And I think sizing of the stents and the length of stents is very important before you deploy. And honestly, it did happen to me, but I saw a couple of cases. I think I saw it and then I searched something and I saw a couple of cases, but I don't know if I know anyone it happened to him.
Yeah, but those are some good tips to avoid it, right? Is basically you're doing a venogram and you're ballooning and you're doing a venogram before you place that stent, to just know where you are, what you're, it's like placing a tips, like where you want it to begin and end, basically.
Let's give you an example. If you do the lower SVC, let's suppose you're doing the lower SVC into the heart, and you just recalize it. You are afraid that you don't want to do a venogram. You don't want to do a venogram, you just want to stent it. You just balloon it a little bit, and you don't want to do a venogram because you don't know what's exactly happened. So what I do in these cases, if I'm not sure, I just go with another catheter. Let's suppose I have an access in the femoral, so I will go another catheter beside the wire and just go into the heart, and just to as much as proximal to the occlusion, and just try to inject and mark my landing zone. If I mark my distal landing zone, then the proximal, I have the access in the arm or the neck, I can do a venogram from there, or I can use also another catheter and just try to size and the stent and to have the proper length. Some of the stents, especially when you want to, some of the stents is very difficult to push, especially the cover stents. You need a sheath crossing the occlusion first and make sure that your landing zone is perfect. So some of the stents doesn't go easily, and even with some dilatation or minimum dilatation of small balloon, in these cases you can use the other axis to just pull your sheath or snare your sheath or push your stent from the other side, just to make sure that you're in the middle of the occlusion. And most of the balloon mounted stent, which is very safe, you just inflate it, and you can see slowly go slow with the pressure, and just live X-ray and see how it reacts. And usually it will prevent the stent to move or go anywhere else.
Yeah, it kind of sounds analogous to tips when I think about it. You're just making sure you're not stenting into the liver parenchyma, into your stents going all the way into the portal vein. You know what I mean? So yeah, it's like injecting your portal venogram and your hepatic venogram at the same time. So you have those, you can mark those spots of where you want your stent to begin and end. So I like that. That makes total sense. So what about in malignant disease? Let's say it's not one of these dialysis patients type occlusions, it's a mass. Are you changing up the way your stent choice or anything like that for those?
But I think I prefer the malignant. I usually prefer cover stents.
Cover.
I think I prefer cover stents. Yes, I think to I don't know I saw a lot of studies usually published or retrospective studies published about malignant SVC. They prefer cover stents, potentially a little bit higher, and also for precise deployment, because some of the lesions, especially if the long lesion, it's very tricky to open self-expandable stents.
Yeah.
And you may have migration, but so most of the cases malignant are huge cover stents. Yes.
So, and then you just, if the mass pushes on the stent, you just bring them back and balloon with like just serial dilatation just to get it to open back up again?
Yeah, exactly. So when you follow up the patients, the patients start to have other symptoms. You just start with either imaging and do venogram, and just do angioplasty to just to give him time with symptom-free.
Yeah.
Yeah.
Do you always try to do double barrel and maintain both upper extremity accesses, or are there times when it's appropriate to like jail off a side?
This is a very nice question. It's depend on the patient. So it's very important to know what's the next for the patient. You don't need just to recognize the chest vein. You need to know what's the next for the patient. So let's suppose the patient have a fistula. You have bilateral occlusion, but you have a right fistula, and he came with malfunction fistula, and he's asymptomatic regarding SVC occlusion. I'm not planning to do bilateral. I'm just going to do like unilateral. Let's suppose the patient have no symptoms, have SVC occlusion, and need an access. I may do only jugular, just from the jugular try to have established access into permacath. But if this patient is symptomatic, or the patient going for transplant, I usually try to recanalize both sides. Just bilaterals.
Okay.
To give them multiple choices, and depend also on the inflow. And to depend on the flow. If for example the patients have a good flow or inflow for bilateral, you know that SVC syndrome sometimes unilateral recanalization is enough. But let's suppose the patient's also dialysis patients, so you just want to open both veins to give them multiple choices for access, because you don't want to go and do femoral. So in our practice, I don't remember the last time I placed femoral catheter. Honestly, I don't like it. I usually try to exhaust as much options and to having an access in the upper part of the body. And so for the planning and the next option for this patient, let's suppose the patient have SVC occlusion and bilateral chest vein occlusions, and they just want to access, and also they want to create fistula. Let's suppose the patient's young. So these scenarios, I prefer to do bilateral, just do bilateral recanalization to give them a chance for a fistula creation, and also to give them a chance to have an access line for dialysis from the other side.
Yeah, the other point that you brought up that is really a good point, I think, is the added inflow that you get to help keep that stent open too, or just to help keep the SVC open from the other side. So femoral access is just, you feel so bad for those patients, whether it be that the catheters themselves seem to clot more often, and to have to do a declot from a femoral access is really painful too.
Yeah, and also it can obscure transplant for these patients too.
Yeah.
So if you have a chronic DVT and now you have occlusion, so not many surgeons, some of them do, but not many transplant surgeons will do transplant in these patients.
That makes sense. All right, well, we are about wrapping up here. Just a few more questions. So just real quick on bailout, what happens, we touched on in the beginning is, it's something that you consent for, is what happens when it doesn't go as planned? How much time are you giving yourself for these cases? And like, when do you give up, if ever?
Okay, so it's usually when I book the case, I usually think that the tips and tricks that I can tell people, start as early as possible. So make it the first case.
Yeah.
You want to be fresh. If you have partners or colleagues, it's very important to have support, and also to time yourself. So these cases usually give 2 to 3 hours. In very complicated cases, sometimes maximum 4 hours. And if I fail, let's suppose I'm trying to do the case, or one of my colleagues trying to do the case, and we fail to do it, usually we ask one of our other colleagues to try. it's not shameful. It's very useful, and at the end we are doing it for the patient care. So sometimes I would just call one of my friends and say, just can you try to do recanalization, and you would be surprised that sometimes you are trying to do sharp recanalization. What if your colleague come with a wire and just go through the occlusions and it's track? So it's very important to time yourself, to ask for help, and it's very important to stop. It's knowing when you stop is very important in these cases.
Yeah.
You don't want to go extreme. Sometimes you know that you are tired at the end of the procedures, and then your mind just blocked, and you just go extreme and do some dangerous thing. You just relax, and you can just stop, and you can really rebook the patients with another approach or another plan, or after discussion with more senior people or more expert people.
What's your do you have an anticoagulation regimen after placing a stent?
Yeah, so follow-up is very important, which is remember we said the 3 points. The 4th point was to know the outcome and complication, which we talked about. Then the last one is follow-up. We need to follow up these patients. So we have a clinic, so we follow up our patients with also other services. And the anticoagulation usually first put the patient in heparin and antiplatelet. So I prefer to put the patient in Exparin and also an antiplatelet. Then after a couple of, especially heparin for at least 2 to 3 weeks, then after that we shift him to Apixaban for a couple of months.
Okay. And then do they stop at some point, or?
Yeah, usually they stop at 6 months if the patients have a good inflow and the follow-up. There is no recurrence of symptoms. 6 months is I think it's most of the cases will stop. On some of these cases, usually patients are already in anticoagulation because of his comorbidity.
Right.
So some of the cases they will shift back to dependent nephrologists and consult of other colleagues like hematologists. They will go either continue with Apixaban to a certain point or to shift in other anticoagulation like warfarin or something else. From my point of view, after stenting, I prefer to have it at least for 6 months.
Yeah, and are you doing any follow-up imaging to determine patency?
Honestly, not every patient. It depends what happened during the procedure and what's the things that I saw. But most of the patients, we follow them clinically. If there is if the patient have a fistula, then we'll do like 3 months or 6 months, we'll do a fistulogram just to make sure that's intravenous still open.
Yeah, it'd be nice to be able to balloon it open rather than wait for it to occlude again.
Close it completely and then try again, yes.
Yeah, but I imagine you're going to get, I mean, that's the case with a nephrologist. Really keep an eye on them at dialysis, making sure the flow rates are good. Keep a close eye on those. So let's see. And okay, one thing I wanted to talk about before we get into kind of final thoughts, long-term patency and restenosis. Are there any published rates for this, or is it just there's such little data around it that we don't have good data around it, and it's maybe case by case? But what's your experience?
I didn't see anything regarding complete obstruction or occlusion of the SVC regarding patency in long-term studies. What I saw is multiple retrospective studies comparing stents like cover versus uncover stents. But honestly, I didn't came across a long study regarding the follow-ups. Regarding our patients, we don't have not all of them will have a long follow-up because dialysis patients sometimes they shift they shift to the other hospitals or go to other countries or other cities. So it's very difficult to have all the follow-ups. But in our patients, we usually have dependent difference from patient to patient. But I don't see any evidence regarding the patency of stenting a lung segment or opening a lung segment of SVC.
Yeah, Jeff Chick sent over a list of articles that mostly describing technique for SVC occlusion and sharp recanalization. So we will post those in the show notes for people. Abdulaziz, any final thoughts? Any good things for like beginners who are just starting to do these that you'd like to leave with the audience before we finish up?
Yeah, so I think it's very important points or take home messages to have a CT scan before and try to study the CT scan very, very carefully, and to know your materials and your support group. So if you want to start these cases, it's doable, but you need to know that you have a support system in your centers, and you need to know what's your available tools, and time yourself is very important also, to time yourself and to know possible outcome and complications and how to deal with it. Most of these cases, it's not that common, especially in a very dedicated centers that treat their own patients. But small of the tertiary centers, you will like face it in near future. So it's very nice to start with a short occlusions. If you want to do sharp, just start with short occlusion to feel the needle in your hand, to feel the case, we feel the action when you do it, and then you can build up on it. But I think it's basically most of IR communities are very capable to do these cases.
Great. Abdulaziz, thank you so much for sharing your expertise and experience on these cases. And to the audience, again, check out the show notes for added resources. And also check out the Twitter posts that Abdulaziz we'll have links to those in the show notes as well. Hey man, hope to see you in Dubai at the pairs meeting in February and actually get to hang out in person.
Thank you so much for having me again. It's really a pleasure, and I really thank you guys. What you're doing is amazing, and hopefully see you in Dubai and show you the Dubai. But I want you also to come to Saudi Arabia.
Yes,
especially with the real season now, and with what happened in the World Cup.
Oh my gosh, man.
Just won, man. We just won, man, the first time against Argentina. So it's you will have fun for sure if you visit Saudi Arabia. But hopefully I can see you in Dubai and just meet you in person. Thank you so much.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritts, and co-hosts
Chris Beck, Sabine Dond,
Michael Barraza,
and Ali Behetti.
Our audio team lead is Kieran Gannon, with support from
Josh McWhirter
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz.
Article and transcript support by Taylor Robinson
and Delaney Aguilar.
Social media and PR by Ann Dang.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening, and see you next week.